Now, moving ahead, we have another esteemed international faculty joining us for the opening plenary session. So, Dr. Tim Leiner, Professor of Radiology from Mayo Clinic. He is also Professor of Radiology from Utrecht University and Medical Center from Netherlands. Dr. Tim is also a passionate teacher, and his main area of interest is into the development and implementation of new cardiovascular MR and CT techniques. He has been part of ISMRM, ESMRMB, SCMR, SCCT, RSNA, and ECR. So you name it and you will see Dr. Tim Leiner everywhere. He has more than 3,500 original papers to his credit, and is also the current editor of Journal of Cardiovascular, JCMR, Journal of Cardiovascular Magnetic Resonance. It is really indeed a pleasure to hear him over here. Dr. Tim Leiner, please. Yeah.
Everyone, my name is Tim Leiner, and I will speak to you today about the future of cardiac imaging. I'm a professor of radiology at Mayo Clinic in Rochester, Minnesota, and it's a great honor to be able to address you this morning. So these are my disclosures. And first, I'd like to walk you through the lecture outline that I have prepared for you today. So first, I'll discuss the one thing that is driving progress towards the future of cardiac imaging today. Then I'll discuss with you the imaging pipeline and the impact of the various new techniques on this process. Then I'll discuss with you what's on the horizon, and I'll finish off with some conclusions. So let's jump right in. And the future of cardiac imaging is all about machine learning. And this will cover the entire pipeline from indication and patient scheduling to acquisition, image reconstruction, and improvements in image quality. Subsequently, once we have these images, they need to be segmented and quantified, and then we should be able to generate reports and attach a diagnosis to these images. Finally, within these images, there's a lot of prognostic information that can be derived. So I think it's safe to say that AI can and will be applied to all of these steps, and this process of optimizing all of these steps is driving the future of cardiac imaging today. So let's show you some examples. So first, let's start with acquisition and reconstruction. And for those of you who are not completely convinced about the clinical relevance of these techniques, I'll try to point out some points that I think can be used for improving. So first of all, if we talk about MR, sequences are still too slow, and examinations may take up to 1 hour, especially in the United States, where we have very comprehensive examinations. MR is too expensive, so scanners cost a lot of money, and improving image quality may allow us to trade off some of that quality in the scanner for cost. And with regard to CT radiation, there's also a lot of things that can be improved. So a lot of patients receive high doses of contrast, and there's still only a few patients are above the age of 50, so radiation impact is still large. So let's look at some techniques that are currently around and that are being deployed by vendors as we speak. So this is some material that was given to me by Jeremy Collins from Mayo Clinic, one of my colleagues. And this shows you on the left the standard acquisition for delayed enhancement imaging of the heart, which is obtained in approximately 4 minutes. Here we have an accelerated sequence, slightly more noisy, obtained in 2 minutes. And on the right here, we have a machine learning improved image. So you can see here that we are able to accelerate and denoise and get image quality that is in fact better than the standard technique. So this is one of the things that's driving progress. Here's some examples from another vendor. So this is deep learning guided K-space denoising. On the left, parallel imaging, 7.3 seconds per slice on this black blood imaging of the heart. In the middle, we have compressed sensing, which is already better at reducing noise. But on the right, we have accelerated images acquired and AI denoised, which allows beautiful delineation of the anatomy with high signal to noise. So these techniques are now starting to have an impact on real daily clinical practice today. And this not only applies to static imaging, but also to dynamic imaging, as you can see right here in this example of parallel imaging of the heart on the left, using conventional techniques, and on the right side, we have a denoised set of images that are looking much better, much more detail, while preserving the spatial arrangement and the contractility evaluation of the cardiac chambers. If you want to learn more about this, we published a meta-analysis with a group of experts on this topic in this paper right here. So what about image reconstruction in CT? So here are some examples of some work one of my PhD students, Jelmer Woltering, did. So we have a chest phantom right here, and this red line across the chest phantom shows you basically the signal intensity profile, and the jitter on this line, if you will, is the noise profile. Now, if we use iterative reconstruction, which you can buy on today's scanners for every vendor, you can see that this noise level reduces. But if you use convolutional neural networks, you can actually do a much better job. And these are the techniques that are now entering clinical practice. So here we have an example in a real patient. So this is an image of a patient who underwent coronary calcium scoring using low-dose techniques with 20% of the normal dose on the left. Iterative reconstruction is able to reduce some of that noise, and convolutional networks on the right can do an excellent job as well, at a fraction of the cost, if I may add that. All right, so these were some examples of image reconstruction, and now let's move on to segmentation. So this is a common task today, and this is, I guess, what most people associate with the implementation of machine learning in clinical practice, and this has driven a lot of progress. So as you all know, segmentation is tedious work. It takes a lot of time. Even trained observers spend a substantial number of minutes to analyze cardiac CT and MR images. And more importantly, time limitations restrict routine extraction of all relevant information in images. So that means we are ignoring a lot of relevant information. And machine learning can also help identify poorly visible structures, as I'll show you an example of in the next couple of slides. So here's some work that shows you a deep neural network-based imaging pipeline that can quantify cardiovascular structures from CTA. It was recently published in JACC. And the nice thing is that these methodological improvements or algorithms can be derived from relatively small data sets, in this case 166 CTs. This was done with a UNet, and the output here is segmentation of LV and diastolic volume, also on the right side, and also for the atria, including LV mass. So this is a really powerful tool to quantitatively analyze cardiac CT scans as we acquire them in routine clinical practice with high accuracy. Here's some of the accuracy numbers. You can see that the identity line is very good with regard to the comparison to human experts, except perhaps a little bit of error for the left atrial volume. But I would say that this is within acceptable bounds for clinical use. Here's some work from our group again that shows you that these techniques can also be used to basically segment cardiac chambers in non-enhanced cardiac CTs, such as used for coronary calcium scoring. So this is an interesting application, I think, and it shows you that these techniques can actually see details in images that humans have a hard time evaluating. So what we did is we trained this network on contrast-enhanced CT, then generated virtual non-contrast images, further improved the network, and then we ran it on calcium scoring CTs. And you can see the dice coefficients up here that are close to 1, which shows you that the accuracy of this technique is quite good and definitely yields useful information from these scans that are not even intended to obtain this information. So here's another example that I'm going to show. It's not just an example of new segmentation techniques or more extensive segmentation techniques, but what you see these days is that these networks are built to not only do the segmentations, but also to perform quality assessment. So it's basically a full pipeline of networks that can compute parameters and output high quality data. So the first step here for this algorithm that was described in JACC imaging in 2020 was to check image quality. Then there's full cardiac cycle segmentation. Subsequently, the algorithm computes parameters, and this is then output in terms of quantitative output, which then can be used for research, for clinical diagnosis, et cetera, et cetera. And so the full pipeline approach is something that is now the state of the art, I would say, that performs all of these tasks based on separate step optimization, if you will. And the nice thing is that these authors have also made this freely available via the author. So if you are interested in using this, contact this author right here, Bram Ruysink. All right, so now let's move on to diagnosis, which is, of course, the next step. So once we have extracted all of this quantitative information, what do we do next? Well, we try to come to a diagnosis, or in case of a follow-up, we try to compare to the initial study. So in this case, machine learning could serve as a second reader. It can be used to triage examinations, but it can also be used to, for instance, to avoid invasive examinations or reduce contrast agent usage, et cetera, et cetera. So, for instance, an example of using texture analysis instead of contrast-enhanced imaging after injection of gadolinium, this paper shows a nice proof of concept study that this technique can also be used to assess the presence as well as the extent and transmurality of left ventricular scarring in patients who have had infarcts. So again, a relatively small data set of 120 patients, 72 with large infarcts, 48 with small infarcts. We can see normal images right here. In the left column, you can see the infarct here. Then the texture analysis was applied on a cine frame, an anti-diastolic cine frame, and this was then compared to the accuracy with regard to the gold standard, which is late gadolinium enhancement. And this texture analysis relies on 286 features from an open source software package. Reproducibility was tested, and both for large scars as well as small scars, the authors were able to show high accuracy for detection of transmurality and presence of scar in patients with known scars. So this is a great example, I think, of, again, extracting information that's hard to see by the human eye, but that is capable of doing, or that machine learning is capable of doing. So this is also an interesting paper that was recently published, and basically the next step after looking at static anatomical images, if you will, is to also start looking at wall motion abnormalities. And the authors here used four-dimensional CT cardiac angiograms to do this. Now what you see here is a pipeline that was built to segment the CT images, but also to generate these 3D volume rendered images, which are computationally much less intensive. So this technique is much easier to actually run on standard hardware in the clinic. And what you see right here is these different views of the heart over the cardiac cycle from end diastole to end systole. And this was then used to automatically diagnose wall motion abnormalities. And this was done in 343 patients who underwent CT imaging in the context of pre-TAVR workup. And again, this approach, by using the volume rendered images, greatly reduces the memory requirements to analyze these images and gives you useful data. Another example in the field of vascular imaging is this work by my colleague Alex Bratt, who has shown that if you use deep learning techniques, you can actually improve reproducibility of aortic measurements, especially over time, and this obviously also is reducing the workload quite substantially, because this is a very heavily labor-dependent task. So here's some examples of this work. So the algorithm automatically determines the location of several anatomical landmarks, and then it can acquire all of these measurements fully automatically. I mentioned in the previous section that it is important to have these fully automated pipelines. They are the state of the art, and this is another example of such work by the group of Damini Day from Cedars-Sinai Medical Center in Los Angeles, who has published this study that showed the capability of deep learning-enabled CT angiography of the heart to quantify plaque in the coronary arteries as well as stenosis, and in addition to that can perform risk prediction. So this is data from 6 centers across the world that were put into creating this algorithm, and then it was validated in 3 additional cohorts that did not participate in, let's say, generating the training data and the derivation data. So this is also for diagnosis and prognosis, the confusion matrix from this paper, so human experts versus deep learning derived CAD-RAT scores and plaque volume as well as diameter stenosis and the relation with outcome derived by these electronic/automated algorithms. So this is a great example of how machine learning techniques are driving the much more quantitative approach to cardiovascular image analysis and are automating risk assessment in individual patients. So now let's look at prognosis in a couple of slides. So as I mentioned in the introduction, images for diagnostic purposes also contain a lot of prognostic information that, for instance, can be used to adjust the intensity of therapy, which is especially important when you are talking about some of the more expensive therapies that are coming to the market these days. And an example of this is the treatment of pulmonary hypertension. So this is work by Declan O'Regan and his group from Imperial College in London, where you see this patient here with this tremendously enlarged right ventricle, hypertrophied right ventricle because of the pulmonary hypertension. There's a new medication on the market, which in the United States costs about $45,000 per year. But wouldn't it be great if we can identify patients who need this most instead of just give it to everyone who fulfills the criteria of pulmonary hypertension? So to facilitate this type of triage, what they did is they used machine learning techniques to automatically segment the right ventricle. And what you see on the right here is these loops on the right ventricle indicate the excursion of the individual pixels over the cardiac cycle. And you can see that there are regions where there's a lot of excursion denoted in red, but there's also regions denoted in blue where there's very little excursion. Now, what they did is they took this type of analysis and put it into a survival analysis network that predicted outcome based on these highly detailed machine learning derived motion patterns. And what this study, or what these investigators were able to show, is that versus conventional MR parameters such as strain, such as RVEF, the machine learning motion analysis is actually better able to pick out patients who do relatively well versus those who do relatively poor. And this is of great importance in the context of, for instance, using these more expensive drugs. Here's some other work that's also quite recent about precision phenotyping of dilated cardiomyopathy using multidimensional data. So this is interesting. For instance, this was done in 426 patients with dilated cardiomyopathy that were precision phenotyped using clinical ECG markers as well as demographic assessment. in combination with advanced techniques like proteomics analysis, genetic analysis, and imaging phenotypes. So this was then analyzed by machine learning techniques, and basically what these authors were able to show is that new phenogroups were able to be identified which have certain combinations of these parameters, which then likely demand different treatments or different intensity of treatment. And this type of work is actually showing us new mechanisms of disease or new clusters of parameters and risk factors that we can measure that portend a different prognosis versus all of these things individually. So this is called precision phenotyping with multiple different modalities, if you will, and this indeed led to the identification of subtypes of dilated cardiomyopathy with a different prognosis. Again, using a relatively small data set, so that shows you the power of these techniques. Was validated in 239 patients and ultimately yielded a clinical model with just 5 variables that are easy to understand by clinicians and referring physicians. All right, so in the last couple of minutes, I want to focus on what is on the horizon. And of course, one of the things that are on the horizon are newer techniques instead of just the plain vanilla convolutional neural networks. For instance, if we look at what is the state of the art today as we speak, it's the NNUNet, and NN actually means no new UNet because it's a UNet that's been optimized for pre-processing and model ensembling, but despite the fact that these techniques are very powerful, there's still a relatively large gap with human performance, and there are difficulties with adapting trained networks that were trained in one domain to applying problems in a different domain. So that means that even if you increase your data set quite substantially, this is a problem that is still present. And for instance, here's an example that was published relatively recently. So this on the left here, we see a UNet versus an expert. UNet was trained on contrast-enhanced CT scans to segment kidneys, liver, and spleen. Works very well in relation or in comparison to a human expert. But if you use the same neural network and then have it analyze non-contrast enhanced CT images, as you can see on the right, then the kidney segmentation completely fails. So there's absolutely a really bad performance for segmenting kidneys. So this shows you this problem of external generalizability of these techniques. So what is the future though? Well, the future is transformer networks. So think networks like ChatGPT. So these have a fundamentally different inner working versus CNNs because they are based on sequence processing. And the way you can think of this is, for instance, instead of learning by example, for instance, in the image domain, what we do is we contour, we train the network, and then we show it non-contoured images and have the network generate contours. Well, what you do with these transformer networks is you train them in a very different way. You basically take images and you leave out certain patches in the image. And it turns out that if you train your network that way, they become much better at the task at hand, plus they are much better generalizable to other tasks. So this has been shown to be very successful in language translation, video tasks. And this is because they have an inherent attention mechanism, these new techniques. So this is also, you may have heard of foundation models or large language models. These are the models that we're talking about here. And GPT then means generative pre-trained transformer. So these are huge algorithms or huge, let's say, models that are trained on billions and trillions of parameters. But you can then, once you've done that, and that's a substantial amount of time and money that goes into that training and huge amounts of data, you can then fine-tune them for a specific task, for instance, in computer vision, and they can also be used in hybrid fashion with conventional techniques like I discussed earlier in this presentation. So for instance, if you look at this graph here, that shows the evolution over time and the number of parameters that are being used in these models, you can see that we now are in the hundreds of billions or trillions of parameters. On these networks, they need thousands of GPUs to be trained. They cost millions to train a single time. So you can imagine why only very large companies like Google and Microsoft and Amazon are able to do this on a large scale. So this is beyond the capacity for instance, a simple academic institute. However, we at Mayo Clinic are working closely with some of these companies to try to build medical versions of these networks. To show you one of the small but relevant improvements that you can see right here. So on the left here, we have the ground truth for segmentation of abdominal organs. In the middle here, we have this new LLM technique that shows you very good correspondence, for instance, for small details in the pancreatic head and the wall of the stomach and the gut versus the simple NNU nets, which typically fail at this task. Now, how are we going to putting it all together? Well, one of the huge opportunities here is to create what we call digital twins. And so the concept here is that you take all of this information that comes out of these neural networks and out of these large language models, and you integrate this into a digital copy of certain processes, but even entire humans. So obviously this is hugely complex, and we're just starting to understand what we can do with these models. But this is definitely the future of cardiovascular imaging and the future of cardiovascular disease management. So creating these digital twins is going to be very interesting. And this is a paper that looks at the applications of digital twins in precision cardiology. And the key concept here is that you have a digital representation of a real world physical system. So we use all of this data that I discussed earlier. We put this into mechanistic models. So we know certain disease processes. So we create models for those things that we know. We create statistical models for some of the things that I showed earlier. And then we combine these two to try to obtain new insights, and also, for instance, to try to obtain what happens if you give a drug, what happens if you give a certain dose of a drug, what happens if you try to create new drugs or attack new certain processes that we don't have on the radar yet. So this will really enable a much better and cheaper way of experimentation with regard to medical therapy. And this will allow the migration from systems describing disease to predicting response. And for instance, in the cancer world, this is already, there are a couple of examples where this has been very useful. For instance, clinical dose response prediction of new immunotherapy drugs for non-Hodgkin lymphoma, and optimizing immunological screening of fecal matter in patients who are at risk for colorectal cancer. So if you want to learn more about this, read some of these papers that I've listed below here. So that brings me to the conclusion of this talk. So the future of cardiac imaging is all about machine learning applied to all of the steps of the cardiac imaging pipeline, and then taking this information and this future is arriving as we speak. So vendors are working hard to develop FDA-approved applications. First applications are now ready for commercial use, but this pace will obviously accelerate tremendously in the coming years. Significant improvements in machine learning methodology are coming, using, for instance, large language models and generative techniques, and this can then be integrated with mechanistic methods and insights to obtain new insights in disease, new management strategies, and this is going to be very exciting in my opinion. As an example, the digital twin technology that I just discussed. So with that, I'd like to thank you for your attention. And again, I would like to thank the organizers for giving me the opportunity to present here at this point in time. Thank you very much.
Tim, just wave us at us if you can hear us. Oh, perfect. Excellent. This is like the dumb charades we can play here now. Thank you very much. That was a real great outlook.
Now?
Now we can. Yes, perfect.
Good to see you.
Thank you, Tim. Thank you. I think the whole audience would really like to thank you for this wonderful talk, because machine learning is something we've all been scared of, perhaps. It's something which we are not very comfortable with, but we are seeing a lot of people adopting it, and you've given us a different outlook to that. So thank you very much, Tim.
Pleasure.
Meanwhile, we set the stage for the inauguration. Sir, I would just like to ask you one question. Like, as a fellow radiologist, I mean, we are busy in our clinical practice but then how do we learn this entirely new field of artificial intelligence and machine learning? What is actually required for a practicing radiologist?
Yeah, that's an excellent question. And obviously, I asked myself that question too. And I think that it's not about learning how to code or to program to be able to understand what is going on in this field. My advice to people interested in this would be to team up with technical experts who are often very interested in working together with you to solve clinical problems. And that's exactly what I did in my practice in Utrecht and also here at Mayo Clinic. So I teamed up with technical experts who can help me solve problems that I have in the clinic. For instance, some of these segmentation tasks that you saw, there are lots of examples that we see in the literature where the expertise that these people have can be applied in concert to, let's say, the human expert. And what's important to realize is that, as far as I know, everywhere in the world, the regulatory authorities still require the design of these algorithms to function in tandem with human experts. Because when you read papers, everything looks very bright and shiny, but if you actually plug these things into your workflow, you will figure out that they are not perfect, and to a certain rate that they cannot be basically left by themselves. So you need human experts to be able to work in concert with these algorithms. So don't be afraid, but do get involved, I would say, because this is the future of radiology and medicine in general. So.
Thank you, Jay. One question. Moving forward, in a decade's time, when we get all these tools on our desktop, on our workstations, and at a click of a button, you have data in front of you where everything is just in front of you. So what's the role as a cardiac imaging specialist would be? Is it just to connect dots, the data which come in front of us, and we don't we decrease our way we do the scanning as well as the interpretation data? How do you look at it moving ahead?
Yeah, that's the million-dollar question, right? How are we going to use all this data and make sense of it? So my personal opinion or expectation is that in the future, radiologists will actually take a much more central role in integrating the information from all of these sources into something that can be used clinically. And my guess is that we will maybe not tomorrow, but at some point in the future, we'll move away from only image interpretation and being responsible for the, let's say, technical acquisition, as was mentioned by the previous speaker, but we will also have a much more, let's say, data science and analytics role in the clinic. So that's what I foresee for the future.
Thank you, sir. And I really thank our platinum sponsor, Vigor Healthcare and AI for Medical Imaging. Because of them, Dr. Tim Leiner is here with us. So So to felicitate Dr. Tim, I request Mr. Bart Hendricks to come on the stage. Yeah. Dr. Noori, yeah. Sir.
Go in the front, madam. You go in the front.
Tim, this is what you're missing. You should have been here for this.
Oh yes, hopefully next time.
Absolutely.
And thank you again for having me. So,
Thank you. Thank you. Any questions, last questions to either Dr. Vanessa Ferreira or to Dr. Tim Leiner? No? Okay, perfect. We're just going to get started with the inauguration.
Yes. So we'll just have a short inauguration ceremony followed by a tea break, and then probably we'll have two groups. The workshop team, the workshop venue is in a different place. We'll have our volunteers who will help you to take you to the workshop venue, and the auditorium, the contents, all the sessions will go on over here. So I